this question. I'm going to discuss question number 1A. The question says, before reading the question, the pattern I want to follow is, along the way, I'll be chipping in some slides that further explain the question asked about that. And at the end of my presentation, at the end of the last question, that's question number 8, I have like 4, 5, 6 slides, of which I will have loved to discuss 2, 3 of them if time permits. So I will be as much as fast as possible. The question says, a 53-year-old man with background hypertension, type 2 diabetes mellitus, previous duodenal ulcer, treated 10 years ago. He developed deep venous thrombosis 2 months ago, and on tab warfarin, 5 milligram Noctu. He returned from a business trip with a central chest pain radiating to the neck, jaw, and back. A history of fever a week prior to presentation. He's obese with blood pressure on the right arm of 125/75 millimeter of mercury, and the left hand of 135/70, with a difference of 10 systolic and 5 diastolic. So the questions are: 1, mention 4 differentials. 2, what are the investigations you'll do? 3, an ECG is given, which showed sinus tachycardia, ST segment elevation in leads V1 to V5. Pathological key wave was seen in lead 2, 3, and AVF, and ST segment depression in lead 2, 3, and AVF. So another questions follow. What is your likely diagnosis now after giving an ECG? Question number 5 read, mention 3 abnormalities in the ECG. And number 6 says, how will you manage this patient? Again, an information was given that there was no PCI in your center, and you decide to give this patient streptokinase infusion prothrombolysis. And the patient subsequently developed blood pressure of 86/40 millimeter of mercury. Subsequently, the patient lapsed into hypotension. So some questions follow after, which list 3 reasons or the causes of hypertension in this patient, and list other complications. So my 4 differentials for this patient are acute myocardial infarction, acute pulmonary embolism, dissecting aortic aneurysm, acute pericarditis. I arrange them based on the one that carry more weight. Why I choose acute myocardial infarction, the reason being that somebody, a hypertensive patient, a non-diabetic patient, an obese patient, coming down with chest pain that looks typical of acute myocardial infarction. In addition, he has history of stressful events. He has history of traveling, and there was history of fever. Likely has some febrile illnesses also along the way. So this strengthened the diagnosis of acute myocardial infarction. Again, one may not throw acute pulmonary embolism away because the patient is an obese. He's 53 years old, and he had prior history of traveling. Though the duration of traveling was not established, however, whatever the form of traveling may pose some risks to development of acute pulmonary embolism. More so that the history of fever, and he had deep venous thrombosis 2 months ago. He's an obese again. So all this also tilt to acute pulmonary embolism. Acute dissected aortic aneurysm is also in contention, being that the patient is hypertensive, he's 53 years old, and he came with chest pain. And chest pain of acute aortic aneurysm mimic that of acute myocardial infarction. And more so that the blood pressure, there's disparity of the blood pressure between the right and the left arm. This is also seen in acute aortic aneurysm. Not only acute, any condition that gives peripheral vascular disease, in addition to acute aortic aneurysm, even coarctation of aorta may cause some disparity in the blood pressure between the 2 arms. So that's also, so below you can see some few differentials that may have 1 or 2 things may fit in some of the presentation of this patient. So question number, so before we move on, I just have some revised clinical features. Clinical features of acute myocardial infarction, the main is chest pain. But this chest pain, in most cases, in more than 50% of cases, is preceded by an event, being an emotional, physical, or even a febrile medical or surgical illness. Like an index patient has a fever and traveling, which could be a stressful event. And the chest pain is classical. It radiates to the neck, shoulder, and jaw. And though the characteristic of the chest pain was not mentioned, so however, chest pain of acute myocardial infarction usually is could be dull, pressured, squeezing form of pain or burning, as the case may be, and radiate to the neck, shoulder, or jaw, upper abdomen, or arm. This chest pain must be differentiated from other differentials in that chest of acute myocardial infarction is commonly severe and may last longer than chest pain of other form of acute coronary syndrome like NSTEMI, unstable angina, or even pulmonary embolism. Some of those with intervention, the chest pain may quickly resolve, unlike in the case of acute myocardial infarction. So it's more severe and lasts longer. And another features that may come, they could come with dyspnea, diaphoresis, nausea, palpitation. Some of these symptoms are due to high sympathetic output associated with the stressful event, with the disease. And sometimes they could come with hypotension, especially if it's an inferior myocardic infarction, which affects right ventricle. So if they have right ventricular infarction, ab initio, or they develop some complications like cardiogenic shock, or even some arrhythmias, they could come with hypertension. So an isolated hypertension is somebody that may not have risk factors or somebody that you cannot explain. One may start to think of acute myocardial infarction. For that, they could come with cold, clammy skin. They could also present with raised jugular venous pressure, and this is if they develop heart failure or RV infarction, or as the case may be. Acute pulmonary edema is one of the way they present, but most commonly when they have complications of heart failure. Heart failure is one of the common complications in this disease. And they could also present with features of ventricular dysfunction, commonly S3, S4. They could also have reduced intensity of the first heart sound, or they could even have paradoxical splitting of the second heart sound, as the case may be, because ventricular dysfunction is features of ventricular dysfunction is markedly seen in this disease. They could have murmur, commonly mixed systolic murmur. However, with some complications, if they have mitral regurg, this is one of the, they could have pansystolic murmur, or even ventricular septal defect, as the case may be. So these are some of the clinical features. The question number 2 says, what immunization will you do? Looking at the top 4 differentials of acute myocardial infarction, acute aortic aneurysm, acute pulmonary embolism, acute pericarditis, patient presenting with this kind of symptom would like to know the pulse oximetry. You want to know the oxygen saturation by using pulse oximetry and act as possible. Electrocardiography is very, very important. It can differentiate almost all the top 4 differentials. In acute myocardial infarction, usually regional wall abnormality, like they could have ST segment elevation, like in this patient, in the particular region affected. Unlike in pericarditis, which are diffuse ST segment elevation with the expression of lead B1 and AVR, and in addition, they could have PR segment depression. And the shape of the ST segment elevation may also differ. For that of acute pericarditis, may be concave upward, unlike that of acute myocardial infarction. So ECG is very important. In the case of acute pulmonary embolism, sinus tachycardia is commonly seen in up to 30%. In addition, they could have McGinn-White pattern of S1, Q3, T3 pattern. Aortic aneurysm may not commonly present with a particular ECG features. Echocardiography is also very important in this patient. It can almost rule out almost all the top differentials. So for the acute MI, regional wall motion abnormalities, if there are presence of thrombus and other essential features of myocardial infarction, unlike in acute pulmonary embolism, which there could be features of RV failure, there could be features of there could be features of 60 pulmonary acceleration time could be calculated, and 60-60 signs could be elicited. Again, McConnell pattern of acute pulmonary embolism could be seen, and some other strain on the right ventricle. And again, pulmonary hypertension almost coexists with acute pulmonary embolism. That could also be seen. Cardiac biomarkers are very, very important in this kind of patient, even though both pulmonary embolism and acute myocardial infection may come with raised troponin. However, markedly raised is seen in patients with acute myocardial infarction. It's important to note that if the chest pain is less than 2-3 hours, troponin may be normal. So it's only likely myoglobin at that time that could be raised. So, but again, the guideline is to repeat serially and compare with the previous ones. So this, our index patient has diabetes. So knowing the random blood sugar is very important. Also knowing the long-term control by using hemoglobin A1C. CT pulmonary angiography is also very important. May detect occluded pulmonary vessel. Cardiac angiography is also important, may localize the particular vessel affected. Chest X-ray, very important, especially in complication of acute pulmonary embolism, or in complication of acute myocardial infarction, or in a patient with acute pulmonary embolism. Some features may be seen like Pallas sign, Westermarck, and Huntington's sign. Other investigation are D-diamonds, foot blocker, and differentials, just like almost every patient. Electrourea and creatinine, kidney function is very important. Arterial blood gas analysis, Doppler ultrasound, serum uric acid. Serum uric acid is an independent marker of cardiovascular disease, and our patient above has cardiovascular. Why I added serum homocysteine is because the patient presented with 2 months prior history of venous thrombosis, and again, he comes down with features of arterial thrombosis. So serum homocysteine is known to be a very good risk factor of both arterial and venous thrombosis. Other screening for this patient that will be important is thrombophilias. Even though he has a risk factor for both venous and arterial thrombosis, we may need to look for other coexisting conditions that may tilt the patient to development of both venous and arterial thrombosis within 2 months. So this is the ECG depicted that may show some of the features highlighted. We just get this ECG in order to match up with the given ECG parameters. If you look, there are obvious ST segment elevation in lead B1 to B5. And again, there is ST segment depression in lead 2, 3, and AVF, but that could be a reciprocal pattern. However, there are pathological Q wave in lead 2, 3, and AVF. I couldn't demonstrate because of the device I'm using. Okay. So then another question follows, that what is the most likely diagnosis? The most likely diagnosis now should be specific diagnosis. Having the ST segment elevation in lead B1 to B5 with concomitant ST segment depression in lead 2, 3, and AVF. I'll make a diagnosis of ST segment elevation by cardiac infarction involving the anterior septal wall, even to some extent lateral. And that's why it became an extensive MI. And I don't want to give more weight to the Q wave. It could be an all-infarct or previously known as transmural involvement. Maybe cardiologists may shed more light. So I just bring this light to highlight some areas affected and corresponding vessels, because that will help in deciding the ultimate choice of the treatment, whether PCI or CABG. So you can see the inferior, you can see the color-coded portion. I think time is not on our side. Move to the next, okay? So another question said, mention 3 abnormalities in the ECG. The obvious abnormalities are sinus tachycardia, SE segment elevation in lead B1, B5 to B5, pathological Q wave in lead 2, 3, and AVF, SE segment depression in lead 3 and AVF, and others. So likely an ECG of somebody with MI, we expect to see other features like QT interval issues if they develop bundle branch block, which could go together with. And again, our index patient is hypertensive. We could see features of hypertensive heart disease, or like features of left ventricular hypertrophy, left axis deviation, P mitral, and other features. So then the next question goes, how will you manage this patient? So management of patients with acute ST segment elevated myocardium depends on the facility where PCI is done, or they don't have an access to PCI. However, the principle of management is to stabilize the patient first, then to relieve ischemic pain, and to institute measures to reduce myocardial damage and prevent further ischemia. So these are an emergency. Of course, ABC obstruction comes first. We look at the airway, breathing, circulation. And this is a patient that best managed to the ICU. So ICU team should be alerted, or coronary cardiac unit in the case of where the facilities, if there is facilities for that. And it's often multidisciplinary, requiring cardiologists, cardiothoracic surgeons, intensivists, even chemical pathologists, because there could be serial monitoring of cardiac biomarkers. So oxygen therapy is very essential in acute management of this kind of patient, because if they need oxygen, they really need to be given. Some guidelines give if pulse oximetry is less than 90, some even 92 to 95, so as the case may be. But however, we should know that a patient that does not require oxygen, an MI patient who do not require oxygen should not be given oxygen. It could be detrimental. It could be just like patient with stroke. If they don't need oxygen, they shouldn't be given oxygen. It could be harmful to them. Analgesia is very, very important. As you can see, this our index patient present with chest pain, and that chest pain used to be very severe. So analgesia is very, very important. The only analgesia approved for this kind of patients are morphine, whether IV oral or aspirin. Other NSAIDs are not indicated because of their harmful effect. They can worsen the condition, they can impair the healing process, and again, they can increase the infarct size. So we should avoid that. So as much as possible, we should stick to this. So IV morphine can be given as boluses, titrated to clinical effect of 2.5 to 5 milligram as initial dose, then titrated to 5 to 10 minutes with further increment. Or fentanyl can be used. Antiemetic is often required because nausea, vomiting is actually with either disease or some form of treatment given to this kind of patient. So nitrates are also very important. They also help to reduce the pain. But again,
Dr. Yaya, you can
yes, sir.
you need to round up. We are above
Okay, sir.
15 minutes.
Okay, sir. In the
Just
next few minutes, sir. Yes, sir. In the next few minutes. So nitrates are also very important. However, we should be cautious in a patient that has RV infarction or somebody with low blood pressure or somebody on phosphodiesterase. However, a good indication for the EIUs is when there is severe hypertension or acute cardiogenic pulmonary edema. Antiplatelet are also very important. Sometimes, like our index patient may require dual antiplatelet, especially if he's going for PCI, and prasugrel is very important in association with aspirin compared to the other antiplatelet. So heparin is very important in this kind of patient. However, our patient is on warfarin. So it's advocated that in an acute setting, it's better to use IV. It's better to use intravenous, either heparin or enoxaparin. So we may need to stop warfarin. After an acute event, we replace with the appropriate anticoagulant. Beta blockers are also very important in this kind of setting because arrhythmias are very often seen in this kind of condition. And again, they can improve oxygen supply and reduce oxygen myocardial demand. So comorbidities. This patient has diabetes mellitus. So at an acute stage, insulin therapy is very important. As we know, hyperglycemia can follow acute MI, or hyperglycemia, MI can cause hyperglycemic state. So we have to actually control the sugar with insulin. And PPI has history of peptic ulcer disease. Even without that, using high dose of this aspirin and some of this analgesic, patient may require PPIs as the case may be. So glycoprotein 2B3 inhibitors, they're also important, especially in a patient that is going for PCI, either given before or during the PCI. However, the ideal treatment for STEMA is PCI, just like our in this patient, in a setting where there is PCI available, or cabbage. So I can say for this patient, is mainly a region of left anterior descending artery. So PCI could be, but again, it's like it involves some part of circumflex vessels. Whatever, the choice for PCI or cabbage depends on whether it's a single vessel affected. If it's single vessel, is an favorable anatomy, it favors PCI. But if it is multiple vessels or unfavorable anatomy, it's preferred to use cabbage. However, some advocated diabetic patients tend to do well, just like our index patient with cabbage. Right. Just these are some of the contraindications to thrombolytics. These are mechanism of this thrombolysis. They convert plasminogen into plasmin. Subsequent plasmin degrade fibrin into fibrin degrading product. Why I use this slide is very important because the subsequent questions, this slide will help us to answer subsequent question. So having managed the patient with this condition, post ACF lifestyle modification is very important. You counsel the patient to smoke, to stop cigarette smoking if he smokes. Then diet to avoid saturated fat, alcohol. Patient should avoid alcohol or should take a set limit of alcohol of less than 21 units in male or less than 14 in female. And appropriate weight control measures should be instituted, like our index patient has obesity. Blood pressure monitoring is very important. It's indicated patients should have blood pressure of less than 140/90, or if he's diabetic, like our index patient, or have kidney disease, should be as low as less than 125/75. Blood sugar control less than 7 is advocated, or HbA1c, less than 10, or HbA1c of less than 7. Adherence to treatment is very, very important. So these are some of the drugs that patients should be discharged with. Because of their time will not permit us to discuss their effects, but they help in remodeling and at secondary prophylaxis prevention. So aspirin, beta blockers, ACE inhibitors, statins, others. There are some recommendations for other use of drugs like mineralocortical antagonists in some selected patients. So these are the acronym for the management of patient with acute management of patient with. So the next question is, list 3 reasons or causes of hypertension in this patient. The question comes after the patient was given, because the treatment of this patient occur in non-PCI center. So where after giving streptokinase, he developed hypertension. So the commonest explanation is streptokinase-induced anaphylaxis, which will come with hypertension. But there are other things. Again, if the patient was given thrombolysis that failed, or he developed infarction, especially RV infarction, or some bradyarrhythmias, again, this patient will likely receive beta blockers and nitrate, which could also cause hypertension. But again, the scenario was given after the patient was given streptokinase. So most likely is streptokinase-induced hypertension. These are the mechanisms: reduction in total peripheral resistance, which is the most common, complement activation, and activation of prostaglandin kallikrein system. So this is the treatment. Some advocated one may not be aggressive in treatment because it's transient. Hypertension seen in them in transient. However, if it persists, we consider withdrawing streptokinase and do some give plasmin activator inhibitors, especially tranexamic acid or aminocaproic acid. So these are the complications. That's the last question. The complication can be divided into based on the duration of how they occur, as we can see, or a pattern of occurrence, mechanism of their occurrence. So we can see arrhythmias, cardiogenic shock as early, and aneurysm, mural thrombus, Dressler syndrome as some of the late that occur a few months after. And these are based on the mechanism. So it could be mechanical, electrical, inflammatory, ischemic, embolic. So that's the end of the questions. I don't have much slides, but time is not on our side, and that's why I just.
Thank you.
So thank you very much for.
Thank you, Dr. Yaya, for a wonderful presentation. So the class is open for contributions, questions, and clarification. Okay, Dr. Mahmoud said morphine, oxygen nitrate, okay, was given a mnemonic, Mona, and then you added Mona B. Yes, it's one of your. Then Dr. Chibuike said glycemic control in MI, the GAMI study, one must be careful with use of morphine in asthmatics with MI, as it potentiates the effect of acetylcholine or bronchial smooth muscle. Dr. Momodu said oxygen supplementation is a standard treatment for all patients who present with acute ACS, regardless of oxygen saturation level. Dr. Afolabi, okay, thank you for the presentation. Dr. Momodu said, although the current European non-ST elevation myocardial infarction ACS guidelines recommend oxygen supplementation if oxygen saturation is less than 90%, and STEMI if, okay, he's trying to correct what he said earlier based on the ACS guidelines. So saturation is less than 90% for NSTEMI, and STEMI if saturation is less than 94%. Dr. Ekele is saying, will it be okay to use clopidogrel since he had duodenal ulcer previously? Then Dr. Tanimu said another cause of hypotension is rupture of myocardial aneurysm. Yeah, I think the others are just saying, applauding your presentation. Okay, Dr. Faisi, I'm not sure if you mentioned lipid profiling investigation, high intensive statin for treatment. I think he mentioned the statin and I think lipid profile. I think those are the comments I have. Okay, Dr. Eunice is saying, please, I need a little clarification. What is the management of this patient's thrombolysis or PCI or CABG? Dr. yeah. Did you get that?
Yes, sir.
Yeah. So you can go ahead and respond to the comments. Okay, before Dr. Temi. Yeah.
Thank you for all your questions. The actual management of this patient had was managed in a center where they don't have intervention, they don't have cath lab, and they've already given thrombolytics. So the guidelines said if you can give thrombolytics within 30 minutes and you think patient can reach intervention center and had intervention within another 90 minutes, you can refer that patient to. So ultimately, all the patients should end up in an intervention center. However, if you cannot get that, maybe before you even give thrombolytics, like an index patient, maybe the time has lapsed for more than 30 minutes or even 90, 120 minutes. The target is for somebody to get PCI or whatever form of the treatment within 120 if he first visited a non-intervention center. So if there is that's not possible, again, you monitor the patient because there is a room for rescue PCI. A patient that had thrombolytics that could not get primary PCI within 120 minutes should be offered to have rescue PCI. So ultimately, this kind of patient that is managed in a certain way, there is no coronary intervention, you may wish to send him to intervention center, whether he's suite for rescue PCI, if the time allows for more than 120 minutes.
Okay. Thank you, Dr. Temi. Can you raise your hand? Can you make your comments?
Yes, thank you very much. Yes, good morning to our trainers, our colleagues, and everybody on the platform. Please, am I audible?
Yes,
yeah,
ma'am.
you're audible.
Okay, thank you, Dr. Yaya, for a very beautiful presentation. I just want to add one or two things.
Yes, ma'am.
Because I remember this exam, and I think that one of the things that they wanted people to mention was actually PCI. But based on this presentation, I'm just going to add one or two things. Once there is chest pain and you're saying maybe, and you do an ECG within 10 minutes of arrival, we call it, you must do an ECG within 10 minutes and interpret that ECG within that time. And you're seeing ST elevation and everything. The ideal thing, just like Dr. Yaya said, is an emergency, so it's PCI. It's PCI. If there is a center close by that can get PCI done within the required minutes, it's PCI. But if there is no such centers, that's when you go ahead and do thrombolytics if it's available. And you can, just like it was done in this patient, they use streptokinase. You can also use alteplase, tenecteplase. Although all these medications are expensive. If patients have reacted to streptokinase before or have used it within the last 3 months, you don't want to use streptokinase again. Streptokinase is the cheapest of all these medications. So you have to do this within the required duration of time, because if you don't, we used to say that the heart muscle, that time is muscle. So if you don't do that, there will just be continuous infarction going on. And this is an extensive MI. It usually have a poor prognosis, even no matter what you do. So PCI is the ideal thing. So rescue PCI, as has been explained, is when you've done thrombolytics and then there's still ongoing chest pain or patient is still not stable. So you still refer to a PCI center. That's rescue PCI. We also have facilitated PCI, in which after you've done everything that you can do medically, maybe there is no center for, there is no place for you to do PCI in your facility. So you go ahead and do facilitated PCI, in which you transfer the person to a center that is close by, maybe through air ambulance or whatever, to get the urgent PCIs done as necessary. Then another thing I want to add is the comorbidities. PPIs can be used here because of the duodenal ulcer that the patient have. High statins, as has already been mentioned, Then they talked about soft softeners for people that have MI. Apart from that, HDU admission or ICU admission with serial ECG monitoring, serial vital signs monitoring, because this patient has extensive MI and is prone to arrhythmia even after all your intervention, and unobserved arrhythmia can still lead to death in this patient because they have very poor prognosis. And apart from that, you manage all the other comorbidities of the patient. Thank you very much, Sazamaz.
Thank you, Chief.
Thank you, Doctor, for a wonderful contribution. While we are taking these contributions, Dr. Alpha Isiaka, Dr. Mosogu, are you ready for your presentations? Dr. Ndukwe Chinwe, Dr. Alpha Isiaka, Dr. Ndukwe Chinwe, Dr. Mosope Orogun, are you ready for your presentation so that you can start sharing your slides while we are taking other comments? Dr. Eguzuzie said, okay, he's just giving the mnemonic, Monad Basic. That's the ACS mnemonic for management of MI. Okay. Dr. Faye said, if initial thrombolysis is not successful, that is fall in ECG less than 50% after 30 minutes, can it be repeated if no access to PCI? So she's asking, can we repeat thrombolysis after 30 minutes and we are not satisfied with the falling ECG? So Dr. Yaya, take notes. Then Dr. Chubuke, in addition, prasugrel will be preferred in patients on thrombolytics over clopidogrel to reduce the risk of rebleeding. Okay. All right, so Dr. Yaya, can you still repeat the thrombolytic after 30 minutes?
Thank you, Chief. I've not across any guideline that says that. However, there is room for, if thrombolysis fail, the best thing is for rescue PCI.
Okay.
Yes, but but ideally you should monitor they should be falling by 50% of the baseline of the ST segment elevation. ST segment should fall by 50%. Ideally, that shows that really the thrombolytics given are effective. However, failure to achieve that, like patient has failed thrombolytics in addition to other symptoms, and that patient, the best managed should be to be referred the patient to an intervention center, where he can have a rescue PCI.
Okay, can you unshare your slide, please?
Okay, let me see if I can.
Okay, okay, Dr. Chibuike says ECG that still shows ST elevation after 60 and 90 minutes are evidence of failed thrombosis, and patients should be referred for urgent rescue PCI.
I think I unshared, right?
Yes, you have unshared.
Thank you.
So this set of people I called, are they in class, Dr.?
Can I share my, good morning, sorry. Can I share my slide?
Yeah, you can share your slide, please. Okay, we can see your slide, so you can go ahead.
Okay. Good morning. Am I audible, please?
Yeah, you're audible.
Okay. Good morning, teachers, the facilitators and colleagues. I would be Shokpetope Orugun. I would be taking the question 5B of West African College of Physicians for October 2022. The question is, a 27-year-old man who weighs 127 kg with a height of 165 centimeters developed exertional dyspnea over 6 months ago. No cough. Patient smoked 10 sticks of cigarettes per day. No known family history of diabetes mellitus, hypertension, lung cancer, or COPD. The lung function test shows a restrictive pattern. 1, what is the diagnosis? 2, what is the cause of his symptoms? 3, what tests will you do to evaluate him? And how will you manage him? Given the history that has been given of the patient, the thought of my diagnosis would be obesity, hypoventilation syndrome, also known as Pickwickian syndrome. One, because of the BMI of the patient, which when calculated is 46.65 kilograms per meter square, and the history of exertional dyspnea that was given. Although one would want to obtain other history to back up the exertional dyspnea, whether or not there is orthopnea, whether or not there is cough, or whether or not there is paroxysmal nocturnal dyspnea. But within the ambit of what is given, exertional dyspnea that's been progressive was given. And then the restrictive pattern that was seen on the spirometry, which would rule out obstructive lung pathologies. And this patient is a 27-year-old man, is quite young. So my diagnosis would be obesity hypoventilation syndrome with pulmonary hypertension accounting for the exertional dyspnea that he is having. The second question is, what is the cause of his symptoms? The morbid obesity, this man has a BMI of greater than 40. That is morbid obesity, and the obesity causes hypoventilation, which leads to daytime hypoxia and daytime awake hypercapnia, and that would lead to pulmonary vasoconstriction, which ultimately leads to pulmonary hypertension, which is why this patient is presenting the way he's presenting. Now, there is history of cigarette smoking, although the duration for which this patient has smoked was not given to us, but we know that he smokes 10 sticks per day. Smoking also causes remodeling of the pulmonary vasculature, predisposes the patient to pulmonary vasoconstriction and hypertension in up to 50% of patients with significant smoking. And the pulmonary hypertension that would be present in this patient would be the class 3 pulmonary hypertension, which is due to lung pathologies like obesity, hypoventilation syndrome itself, or interstitial lung diseases or other pulmonary pathologies. And what tests will you do to evaluate him? To start with, I would love to do a chest radiograph, which may show peripheral pruning and may show cardiomegaly. Cardiomegaly may be present in this patient because it is also not unusual to see that these patients have left ventricular hypertrophy, amongst other things. However, it's said that because of the habitus of the patients that have OHS, that it may require a very skilled and experienced radiologist to be able to pick out some of the features that may be found on the chest X-ray in this patient. Then high resolution chest computed tomography would also be important in this patient, especially to rule out interstitial lung diseases, in which case one would be looking out for reticulonodular shadows and honeycombing. If they are absent in the patient, it would further lend credence to the thought of OHS, in which case we do not expect to see these features. Also, room air arterial blood gas would show hypercapnia in the patient, hypoxia. This is one of the 3 cardinal points of making of diagnosis of OHS. Then a polysomnography would be done in a sleep laboratory. especially if the patient's hypopnea index is more than 5 events per hour. This will be significant if the patient has apneic episodes of greater than or equal to 10 seconds, and if the patient has more than 5 events in 1 hour, then this patient should have a polysomnogram done. This is important again because 90%, up to 90% of patients with OHS would also have an OSA, which is obstructive sleep apnea. And it is said that up to 70% of them will have severe obstructive sleep apnea. Then echocardiogram will also be important in this patient. We can use that to measure the pulmonary, to check for features of pulmonary hypertension, right atrial enlargement, right ventricular hypertrophy, and core pulmonary. Then electrocardiogram may show sinus tachycardia, right bundle branch block, right ventricular hypertrophy, and right atrial enlargement. Pulmonary catheterization can be used to measure the pulmonary arterial pressure in the patient. How will you manage? First of all, I would like to take further history in the patient, one, to ascertain other complications of obesity that may be present. We know that these patients are also predisposed to coronary artery diseases, they are predisposed to cancers, and then also to check for other comorbidities, although it's been said that this patient doesn't have hypertension, doesn't have diabetes, but those will be comorbidities that would also need to be checked for. On examination, these patients may have pedal edema, may have cyanosis, a loud pulmonic component of the second heart sound, left parasternal heave, and tricuspid regurgitant murmur may be present. Other things that may be checked for the laboratory investigations, a serum electrolyte, urea, and creatinine may be important. Especially, it's said that if we have a serum bicarbonate of less than 27 millimoles per liter, it in up to 97% of patients has a good negative predictive value. And a complete blood count may also be important in them, especially we may see features of polycythemia, and if there is a presence of infection, we may see a septic picture. The treatment of these patients will be multidisciplinary. A pulmonologist will be needed, sleep specialist, cardiologist, a psychologist, even general surgeons and nurses will be needed. The treatment is majorly stands on 3 prongs. One is positive airway ventilation. The second is pharmacotherapy, and the third will be surgery, majorly bariatric. For positive airway ventilation, a CPAP, continuous positive airway pressure, or a non-invasive ventilation method may be used. Both of them are equally used. However, non-invasive ventilation is preferred, especially in patients who have milder OSA symptoms or no OSA symptoms at all. Studies that have been done previously found out that NIV reduced pulmonary hypertension better than in CPAP, especially in the short term and in the medium term groups, and is of advantage even regarding other comorbidities that may be present. Then positive. Okay. Then positive airway pressure is associated with weight loss in patients from the randomized control trials that have been done before. It is advised that these patients should not be placed on isolated oxygen therapy, as in some of the studies done to worsen the symptoms of the patient. So there was no difference in between CPAP and NIV in the long-term group. However, in the short-term and the medium-term groups, NIV seemed to have advantages better than CPAP. For pharmacotherapy, first for the non-pharmacologic treatment, the dietary modification is important, especially as obesity lies at the core of this disease. So dietary modification may be needed for weight loss, and then exercise also needed for weight loss. In this patient who was smoking, there will be a need to stop smoking using the 5 A's of ask, advise, assess, and assist, and arrange. And in a case where the patient requires medications for those, varenicline and bupropion would also could be of help in the patient for smoking cessation, as well as nicotine replacement therapies. Then anti-obesity medications, e.g. Orlistat, which is aimed at weight loss, would be used. However, weight loss of 30% of body weight is advised in them. Usually, medications are unable to achieve this, so bariatric surgery would also be important in them to be able to achieve this much weight loss. Drugs for pulmonary hypertension would be needed in these patients, like endothelin inhibitors, epoprostenol, and phosphodiesterase 5 inhibitors like sildenafil can be used in the patient. Then surgeries, bariatric surgery for significant weight loss, as it has been said that patients that achieve significant weight loss can actually have a potential resolution of symptoms. And then in cases of severe OHS, there may be a need for heart lung transplantation and atrial septotomy, especially in end-stage pulmonary hypertension. To go a bit over obesity hypoventilation syndrome, it's also known as Pickwickian syndrome. Is
Please,
attached as the
Dr.
yes.
Mosope,
Yes, sir.
just highlights when we'll
Okay.
get this. Yes.
Okay, sir. Then it's a combination of the diagnosis is made when we have 3 of these, which is obesity of BMI greater than 30 kilograms per meter square, daytime hypercapnia measured by PaCO2 at sea level of greater than 45 millimeters mercury, and sleep disordered breathing. The pathophysiology, essentially obesity-related changes in the respiratory system. It is said that fat prevents good respiratory excursion and diaphragmatic excursion too. Then alteration in the respiratory drive and breathing abnormalities during sleep. The differential diagnosis, one would have to rule out COPD, interstitial lung disease, diaphragmatic paralysis, emphysema, and opioid overdose. This has been said before that there will be a need for a sleep study and an arterial blood gas to be done for diagnosis to be made. And I made this statement about serum bicarbonate earlier. Then complications are usually cardiometabolic, some of which may be systemic hypertension, coronary artery disease, even right heart failure. Sleep OSA can be evaluated using the Epworth sleepiness scale, and a score of greater than 10 signifies OSA with varying degrees. This is a picture of the Epworth sleepiness scale. Treatment is majorly multidisciplinary, and management involves positive airway ventilation and weight reduction and treatment of comorbidities, follow-up and monitoring. Patient could potentially have a resolution of symptoms if there is significant weight loss and maintenance of the prescribed lifestyle modifications. Just to state about pulmonary hypertension a bit, I won't bother to say this. Then, thank you so much.
All right. Thank you, Dr. Mosope, for the wonderful presentation. So it's time for comments, contribution, questions. Okay. Dr. Chibike saying it would have been worthy to mention semaglutide for weight loss in this our current era for OSAS or OHS before bariatric surgery, since it's non-invasive. Okay, I think Dr. Mosope was saying
Okay,
the
sir.
target
Thank you.
for,
Thank you, sir.
yeah. So, but again, you have the target. You say the target is greater than 30%. So most medication might not achieve those targets. So bariatric surgery comes into play. I think that's what you said,
Sure.
Dr. Mosope. Right?
Yes, sir. Yes, sir.
All right. Any other questions? Any contributions? Contributions, questions?
Hello, yeah, good day. Dr. Asa, once the BMI is actually more than 40, that's an indication for a bariatric surgery. So
Okay.
once BMI was more than 40, so that's an indication. Thank you.
Okay. All right. Thank you very much.
Thank you so much.
Dr. Success is asking, what is idiopathic OHS, obesity, hypoventilation syndrome? Dr. Mosope.
Okay. Thank you. Well, I didn't really read so much about that during preparation for this, but I guess it will be idiopathic if there are no obvious causes, especially if obesity itself could not be substantiated. I know that I really came across that, but that's what I think. I don't know if there is any other person that can help shed light on that.
Dr. Success, do you have an idea, or wait for a pulmonologist, any pulmonologist that could shed more light on that?
Good morning, all. He's right in his answer, so that's why I wanted the pulmonologist to tell us if they've had cases like idiopathic obesity hyperventilation syndrome, where there's no identifiable cause and it's not related to a background obesity. So that's why I had to bring that up. Thank you.
Oh, okay, Dr. Jafar. Dr. Momodu, you can go ahead.
Thank you so much. Good morning, all. Dr. Mosope, thank you for a beautiful presentation. What I just wanted to highlight is some of the to fill in some of the gaps. So the OHS, or Pickwickian syndrome, is a diagnosis of exclusion. Okay, so if you look at the question, the way it was even laid out, they gave you things to just take away some of those comorbidities out. So it's left for you to now investigate and probe further to see that there's nothing as much at risk outside the cigarette smoking that was even given to you to actually increase the risk to potentiate maybe the hypoventilation syndrome, and you just opposing that with the BMI to actually give you that diagnosis. Also, you should know that this is quite common, most especially within the fifth and sixth decades. But the age there is 27, I guess, 27 years old. These are some of the ways to just quickly take you off, but you can still stand on that diagnosis. My main thing here is that in terms of the pathophysiology, it's quite important. There's some parts left as particular to it. Normally, we have obese individuals, okay? There's actually what we call fatigue. They have increased breathing demand to actually maintain breathing. There's increased work in the muscles of their muscles, both external and internal, to maintain inspiration and expiration. Increased work, and they do that. They have a normal reflex response from the central centers that will help them increase that. But for the Pickwickian, is lost. Then there's also an hypothesis of leptin. It said that, leptin increases satiety and helps with those who are is secreted by adipocytes. Typically, it's supposed to promote ventilation. But here, in excess, most especially for obese people, it now downplays respiration, reducing it. Then the normal reflexes too, to support, you see, majority of the overload, the overwork of the breathing leads to carbon dioxide generation. So they tend to have more like a metabolic acidosis over time. And then the body tries to reciprocate. That is lost in Pickwickian syndrome. That's why when you see them even in daytime, as compared to the other ulcers, although it can occur concurrently, they have daytime hypercapnia. Okay, over time as they sleep, these are some of the factors that actually gives them all of these distorted a breathing relationship, whereby over time becomes chronic, then begins to cause vascular changes within the pulmonary vessels that might lead to the pulmonary hypertension. Outside the fact that there may be other contributory factors like the smoking that can cause the remodeling. So of note is that for those who are fat, they have a very heavy load on their inlets, most especially the neck. You could also have them having those that have lactonsis. The fat part concerning and their neck reduces the amount of air, you understand, that goes in. So all these cumulative factors are what predisposes them. Then when you have in a situation of all this, and you still, despite being a diagnosis of exclusion, you understand, and you check, you do not have any factor to say other than the obesity, then we'll say it's idiopathic. We do not know the cause. Okay, sometimes it might be as a result of some reversible disease, some people having those large tonsils or the adenoid swelling. It might be due to all those people who pour Mallampati score, or those difficult to intubate airways that have reduced the way air goes in. So the ultimate thing is that there's over time chronic hypoxemia too, because there's not much enough oxygen that goes in into the lungs. Okay, so in that way, if you search everything, you still don't get it. We typically would say is the idiopathic obesity hypoventilation. Then you made mention of there's something I wanted to clarify. Please, the other pulmonologists can also come in. You made mention of something that I wanted to correct. I don't know, Dr. Mosogbe, you said the type of pulmonary hypertension is type 3. Is that what I heard? I wasn't too sure. Hello, sir. Am I being heard?
Yeah, you are being heard. Dr. Mosokwe, are you still around?
Because
yes,
yes.
sir.
Because is it a type? Because you said a type 3 from a respiratory cause. Because the classification generally, when you look at our pulmonary hypertension, the primary one, which is typically 4 to most times, is put within the one, either 1 or 5, where you cannot really classify it. When you see the cause, you understand, it's not entirely coming from a respiratory angle, just like that. So there is some, how do I put it now, controversies between that. Then the use of the non-invasive ventilator, CPAP is one of the non-ventilatory methods that you can use to give them. What is advocated is the fact that these days, some of them, there are different types of CPAP that we use. Some of them might even use a BiPAP, whereby we are giving oxygen and then we're also controlling the expiratory pressure. CPAP is just one way. And most times, the newer devices for the CPAPs typically will have a two-way that will monitor the way they are actually responding in respect to the hypercapnia that they have, to try and correct it. So all those studies, they are a little bit backwards. There are newer ones now that tell us that it's with the patient's symptoms and the patient's data that you use in managing them. They have a hypercapnia, which makes them wake up with early morning headache. You understand? So you in managing them, some with the mild one can go for even the CPAP or some BiPAP with some controlled pressures. Okay, but inspiratory and expiratory. I don't want to push much on that. Then the mainstay for management for these patients, obesity hypoventilation, is lifestyle modification. They have to lose that weight, they have to do exercises, and they have to eat healthy in ways that will help them. Then when these measures then reduce all those comorbid conditions that can predispose them to more problems, like stop smoking, quit smoking, reduce alcohol intake, you understand? Then when that fails, you now want to go into some other measures whereby you can reduce this weight. Drugs too are important too, but it's been said that even with the bariatric surgery or with lifestyle, it's been able to help at least 20 to 30% of them to get a better quality of life, because if not treated, their quality of life is so poor. It's very bad, and just as you said, it can lead to those cardiometabolic complications. So it's quite important we preach that first part, the reduction, especially lifestyle modification. They want to hear that lifestyle modification for the patient. There are various methods that we can use. We know in terms of losing weight, to even locking the jaw or other things, but they are quite important. Then the next step, as you said, the 5 A's we used to stop the smoking. Very, very key, very, very essential for this patient, especially that is taking the cigarettes. I don't know if there are more things for that. Thank you.
Okay, thank you very much, Dr. Momodu, for a wonderful contribution to this topic. Okay. Dr. Rukaya said your slide on pulmonary hypertension looks like you quoted mean pulmonary arterial pressure of greater than 25. The current cutoff is 20, okay, to aid early diagnosis and treatment to improve outcome. Okay, diagnosis, Dr. Faye Sarah said diagnosis of OHS cannot be made in the absence of obesity. Okay, then Dr. Ikwa said, okay, BMI for bariatric surgery, BMI greater than 35 kilograms per meter square with comorbidity and BMI of greater than 40. Okay, that's that for the contribution. Thank you, the presenter. I think our time is fast. We couldn't take it. We'll not be able to take the third question today. I'll hand over to Dr. Christabel.